As we all know, esophagus cancer incidence increased by 44% in the last 2 decades. But parallel to cancer-related surgery, we can see an important increase of iatrogenic perforation due to endoscopy maneuvers. Some of those cases can be treated by clip or endosponge, but large perforation may need esophagectomy. Here we can see the 2 main surgical techniques to make a partial or total esophagectomy. In the first case, the anastomosis is intrathoracic. In the second case, we perform a cervical esophageal anastomosis. In this meta-analysis of 13 studies, including more than 2,400 patients, is reported a significant difference of rates of anastomotic leaks of about 13% when performing cervical anastomosis and only 6% when performing intrathoracic anastomosis. Due to the high risk of leaks, especially in cervical anastomosis, as we already do in colorectal surgery, some groups began to use indocin in green fluorescence to study the vascularization of the tubulized stomach. This meta-analysis shows that the use of ECG results in a significant reduction of anastomotic leakage. But ECG does not give a quantitative value of the perfusion, and in some cases can be difficult to decide where to perform the anastomosis. For this reason, we decided to try hyperspectral imaging technology to assess tissue oxygenation. As you can see in the picture, this tool gives us also other information, such as perfusion index and hemoglobin index, but this index can be high also in hematomes, and a water index. Hyperspectral imaging generates a hypercube that is a 3-dimensional dataset of 3D image of each wavelength that can highlight the tissue characteristics as shown before. Our case is about a woman of 82 years old admitted in our department after an iatrogenic perforation of about 8 cm of the proximal esophagus during an oral intervention for the treatment of an inflammatory stenosis of more than 50% of the cricopharynx. Due to the huge perforation, we initially performed a esophagectomy with cervical terminal stoma and a feeding jejunostomy. After 4 months, we readmitted the woman for the reconstruction of the oral intestinal continuity. We performed a laparotomy with an intensive adhesiolysis and mobilized the stomach with the section of the Barthellis ligament and gastrocolic ligaments, preserving the vascular arcade. We then cut the short gastric vessels, the left gastric artery and vein. Then we performed a Cooker maneuver in order to complete the total mobilization of the stomach. The tubulization of the stomach was then done by 8 charges of a violeted 45 mm endogia. We then perform a cervicotomy, prepare the proximal esophagus, and make a retrosternal tubulization up to the cervical region. Finally, we pulled up the tubulized stomach up to the cervical region. We then selected the anastomotic line for a terminal lateral anastomosis, evaluating the color of the stomach, and check it after with hyperspectral image tool. The analysis shows that the line selected had an O2 saturation of 59%. Instead, the saturation increased up to 80% a few centimeters distantly. We then decide to change our operative strategy and to perform a terminal-terminal anastomosis on the level where 80% saturation was documented. We checked the anastomosis with oral contrast at the 5th postoperative day and with endoscopy at 3 months after the surgery. No stenosis or anastomotic leakage was found. Although this is just a first experience, hyperspectral imaging analysis may be useful in esophagectomy, especially in those patients where a cervical anastomosis is needed. Of course, this is just a first case, and other studies have to be performed to better understand the role of this new technology in esophageal surgery and provide its availability to decrease postoperative complications. Thank you for your attention.